YouTube family, welcome back to the channel. Today we are going over some of the most common vasopressor drip that often being titrated in the ICU. So if you are a critical care ICU nurse and or preparing to take your CCRN exam certification or even studying for your interview for CRNA school, this recap of vasopressor drips hopefully will be a great resources for you to support you in your journey. So with all that being said, let's go ahead and get straight in. Okay, you guys. So ICU vasopressors recap. So please follow me on my Instagram. All right. So before we start on the actual vasopressor medication, these are the three receptors that you guys must know because these have vasopressor targeting these receptors. So in order to understand how the medication works, you have to understand how the receptors works, right? So three receptors you guys must know are alpha-1 receptor, beta-1 receptor, and beta-2 receptors. Alpha-1 receptors present on smooth muscle like of the peripheral vessels, so they are on arteries and veins, right? So alpha-1 receptor, when they are stimulated, meaning when we give them a alpha-1 agonist, those are like Levo or phenylephrine or even epinephrine, they have a direct effect on the veins and also the arteries. On the arteries, they increases the SVR and they squeeze this artery, they constrict this artery, make it harder and make it squeeze so it's smaller, so it increases the pressures, the SVR, the resistance of the vessels, therefore increases blood pressure and afterload, right? So on the vein, it also constricts these veins and causes these veins to squeeze so that more blood can go up right back to the right side of the heart and obviously back to the right vena cava and also right ventricle, atrium and ventricle. Therefore, because it increases, the more blood go back to the right atrium, so it increase the preload, which is CVP, and therefore increase stroke volume, which is how much blood being pumped out per contraction of the heart, right? So per beat, and ultimately increase cardiac output. All right, so alpha-1 receptors vasoconstrictor make the vessel squeeze and constrict the vessel, therefore increases blood pressure, SVR, afterload, and also preload. Okay, next we have beta-2 receptors. Beta-2 receptors present on nodal cells, which are AV node and XA node on the heart, and also contractile cells of the heart. So by knowing where they are locating, we able to tell what function they might elicit when stimulated, right? So when we give them a beta-1 agonist, these will stimulate the beta-1 receptor and elicit these response. So on nodal cell, it will increase the heart rate and also because uh, and also ultimately increase cardiac output, because what is cardiac output? Cardiac output increase equal heart rate times stroke volume, right? So if we have a higher increase in heart rate, it can increase in cardiac output, but obviously too high of a heart rate will also not good for cardiac output as well, because the heart doesn't have enough time to reload, right? Then we have contractile cells. When beta-1 receptor on contractile cells are stimulated, it increases the contractility, meaning that it increases the forceful of how the heart beat, and therefore increase stroke volume, which is the blood pumped out by the heart per beat, and also increase cardiac output. Next, we have beta-2 receptor. Beta-2 receptor present on the lungs, particularly specifically on the bronchioles. So it's act like albuterol that we often give for asthma patients. So these receptor, when stimulated, will elicit a response called bronchodilation. So the bronchioles will be dilated, and also these beta-2 receptor, beside present on the lungs or bronchioles, it also present on the mast cell. These mast cells are responsible for producing or releasing histamine. Histamine is often the cause of bronchospasm or bronchoedema, especially in anaphylactic reactions. So that's why when we give beta-2 agonists, such as epinephrine, it can help preventing these mast cells from or inhibiting these mast cells from releasing histamine and stop the bronchospasm and bronchoedema, and also dilate the bronchioles so that the patient can breathe, and also decreases the pulmonary vascular resistance. Therefore, the heart can beat better as well. All right, so just to recap, alpha-1 receptors constrict blood vessel, increase SVR, increase blood pressure, increase afterload. Beta-1 receptors, these are on nodal cells and contractile cell. It increases the heart rate and increases the contractile of the heart, make it beat more forcefully, more blood coming out. Beta-2 receptors will cause a bronchodilation, make the patient breathe better, and inhibit the release of histamine. So it's good for anaphylactic reactions. All right, so now we know about the receptors. We're moving on to first vasopressors that in the ICU that we often use. So we're going to go from alpha-1 to beta-2, okay? So first and foremost, phenylephrine. These are often also called NEO in the ICU. So phenylephrine is the drip that is medications that pure alpha-1. So this only target alpha-1. And what was alpha-1 again? Constrictor of the blood vessel. It squeezes the blood vessel on the arteries and the veins. So increases the blood pressure, increases the systemic vascular resistance, and increase more blood back to the right side of the heart. So they are called vasopressors, meaning constriction of blood vessel. So again, it increased SVR, increased afterload, squeeze more blood back to the right side of the heart, and increase preload, stroke volume, and cardiac output. So ultimately, phenylephrine is used to increase blood pressure, right? So useful for hypotensive patient in vasodilatory shock. What is vasodilatory shock? Vasodilatory shock is sepsis. For example, these patients are hypotensive because of the dilation of the blood vessel due to the release of cytokines and illicit inflammatory response of the body to the infections. So, however, the reason why ones may choose phenylephrine over levophed, which also have a significant effect on the blood pressure by causing vasoconstriction, is because of heart rate. So for phenylephrine, because it's pure alpha, it does not affect beta-1 receptor, remember? So that's why it does not cause an increase in heart rate. So even though levophed is the first line treatment for sepsis, the doctor may use or choose phenylephrine over levophed because of this reason. Maybe the patient having significantly high heart rate, so we may want, but still hypotensive, we may want to switch to phenylephrine instead of continuously using levophed at higher dose to stop the increase in heart rate in that patient, right? So what to watch out for phenylephrine when we titrate this medication. So because it's a vasoconstrictor, so it can cause peripheral and visceral constriction. So what that means is when it's constricting the blood vessel, the peripheral veins and peripheral artery may suffer. The fingers and the toes may not get very well perfused, and also visceral arteries are blood vessel that branches off the aorta. It perfuses the intestine, kidneys, and livers. So when we give medication that are vasopressor, they usually shunt the blood back to the central, which is the lungs and the heart. So the kidney, the liver, the intestine, and also the toes and the fingers are suffer perfusions wise. So we have to watch out for these perfusions issues of the peripheral. Okay. So that's one, phenylephrine, pure alpha-1. Okay. Next, second medication is norepinephrine Levo. So this is probably the first line. Every time a patient is hypotensive, we always went to the Pyxis and grab a Levo bag as soon as we can. Because it's just so effective and it's so common use. It's also the first line treatment in the for sepsis in the ICU, right? We're all familiar with this medication. So it is I know pressure. I know mean contractility. So it increases the cardiac contractility, and pressure is a peripheral vasoconstriction. So norepinephrine have a stronger alpha 1 than beta 1 effect. It affects both alpha 1 and beta 1 receptors, but it have more potently illicit response in alpha 1 receptors. Okay, so again, what is alpha 1? Alpha 1 again is constricting the blood vessel, therefore increases the systemic vascular resistance, and also the ultimately increases the blood pressure by constricting the blood vessel, so make it more the pressure is higher for the blood to flow through. What is beta 1? Beta 1, remember, is located on the nodules of the heart and also contractile cells of the heart. So it makes the heart breathe more forcefully and therefore increases cardiac output, right? And also increases the heart rate because it's on a nodal cell, which is the AV and the SA node. So what is it used for? It's used for patient in hypotensive refractory despite adequate fluid resuscitations. So that's like a mouthful, but hypotensive refractory basically means that these patients are hypotensive and we given already fluid to improve the blood pressure, but it's still low. It's refractory. It's not responding to treatment. So for this, that's why we give norepinephrine. And again, norepinephrine is the first line treatment for sepsis, right? And so we might, again, we might choose phenylephrine over norepinephrine in the cases where patient have significantly high heart rate because norepinephrine targeted beta 1 receptors as well. So it can cause an increase in heart rate. So if the patient heart rate already 120, 130, or like already tachycardic, so we may want to switch to phenylephrine to keep maintaining the map of over 65, but also not increasing the heart rate, okay? So what do we watch out for norepinephrine? So watch out for tachycardia and peripheral ischemia and visceral constriction. So again, it's also a vasoconstriction. It can constrict the blood vessel that are perfusing the intestine, liver, and kidneys, and also fingers and toes. So therefore, we have to watch out for those, okay? Because it's a vasoconstrictor, it shuns the blood back to the central organs, the heart and the brain and the lungs, okay? So number 2, done. Epinephrine. Epinephrine, this is like a kick everything, like everything stimulated medication. Epinephrine we give in cases of ACLS protocol. In case the patient is during a COVID blue, we give 1 milligram of epinephrine every 3 minutes. This medication will target all 3 of the receptors, alpha 1, beta 1, beta 2, every single thing. It's a kick everything all medications. Also, it can be used for anaphylactic reactions as well. And the reason why is I already mentioned above that it target beta 2 receptors. And what is beta 2 receptors? Beta 2 receptors present on the lungs and the mast cells. So not only it causes bronchodilating of the lungs, but also preventing the mast cell from releasing histamine that could causes a anaphylactic reaction, meaning bronchospasm or bronchial edema, right? So again, epinephrine is an ino pressures. It increases cardiac contractility and peripheral vascular constriction, peripheral vasoconstriction. So at low dose, it is heavy beta agonist, beta 1 and beta 2. So what is beta 1 again? Increases heart rate, increases contractile, and beta 2 is bronchodilating. And at high dose, it target alpha 1 more. Okay, so what do we use for epinephrine again? We use in vasodilatory shock, for example, like sepsis, again, it's not a first-line treatment for sepsis. Levo is cardiogenic shock because it targeted beta 1 as well, so it can cause an increase in heart rate and contractile, and also anaphylactic response and ACLS protocol. So for epinephrine, we have to watch out for tachyarrhythmias may also cause increase in lactate production because beta 2 affected the liver, so it may cause at first an increase in lactic acid production. So usually remember after a code blue, obviously we do a rainbow lab. We also check their lactic acid and often it's elevated. So because we've been giving a lot of epinephrine for the patients. So yeah, so that's epinephrine. Next, we are going to go to number 4. This is dopamine. So dopamine is an inoconstrictor. What is inoconstrictor? So ino is contractile of the heart, right? It's increase the contractile function of the heart. It make it beat more forcefully. And also constrictor, meaning it increases the vascular resistance. So dopamine is dose dependent. Low dose dopamine often targeted beta 1 receptor more but it's affected beta 1 dopaminergic and alpha 1 receptors. At high dose, dopamine is more like a pure alpha 1 receptors, but we don't usually give dopamine at high dose, meaning more than 10 mcg per kick per minute. The reason is because if we want alpha 1 receptor, we can just use our Levophed or phenylephrine. We don't have to make the person go through this much drug of dopamine in order to achieve the alpha 1 receptors. So high dose dopamine are often not really used. We often use anywhere between less than 10 mic per kilogram per minute. So low dose are often being used. So for dopamine, dopamine, besides targeting beta 1 receptor and alpha 1 receptors, it also targeted something called dopaminergic receptors. And dopaminergic receptor produce a vasodilating effect on the renal, mesenteric, coronary, and cerebral vessels, much more renal mesenteric, meaning the kidney. Okay, so dopaminergic is beta 1 agonist at low dose. Agonist meaning that it's when it's attached to the receptor, it's elicit the response. And it's often used for symptomatic bradycardia. So if your patient have a heart rate of less than 60 and it's go down to 50s and then 48s, and then it reflect that on the blood pressure, meaning symptomatic bradycardia, the patient have both low heart rate and low blood pressure, dopamine will be a very good choice because it have a potent effect on the chronotropic. So dopamine affects beta 1 receptor, right? And we know that beta 1 receptors are present on the nodal cell, which is the AV node and the SA node, and also it's present on the contractile cells. However, for dopamine drug, it's more potent on the nodal cell. So it's elicit more chronotropic effect, which is increasing in heart rate. So that's why dopamine will be a great choice for someone who are symptomatic bradycardia. And in high dose, again, it became more of an alpha 1 vasoconstrictor, but we don't usually use this, okay? So what do we watch out for dopamine? Tachyarrhythmia, meaning high heart rate and a irregular heart rhythm. All right, lastly, of our most common vasopressor drip in the ICU is dobutamine. So this medication is often very confused with dopamine. So dobutamine is also an inodilator compared to an inoconstrictor of dopamine. Okay, dopamine, besides causing a chronotropic effect in the heart, meaning increasing heart rate and contractile, it's also caused a vasoconstrictor. However, in dobutamine, it caused an inodilator. So it's increased the contractility of the heart, I know, but it's vasodilate of the peripheral vessel. It's vasodilate of the peripheral vessel, okay? So again, it's also a beta 1 agonist meaning is targeting the nodal cells of the heart and contractile cells of the heart. It increases the heart rate and increases the contractility and therefore increases stroke volume and cardiac output. So we usually use dobutamine for cardiogenic shock. Okay, so dopamine is usually for symptomatic bradycardia, whereas dobutamine is used for cardiogenic shock. These patients are put on dobutamine because they probably have left ventricle heart failure, low ejection fraction, low cardiac output. So we give them dobutamine so that the heart can be it can vasodilate, so more preload, and also the heart able to breathe beats more forcefully, and therefore the cardiac output come out of the left ventricle, the stroke volume is higher. So it's a great drug for cardiogenic shock, meaning that when the heart is not contract forceful enough to projectile blood out of the heart. So obviously we don't want to give dobutamine for someone who have AFib RVR. AFib RVR is obviously AFib rhythm that have a heart rate of more than 100, 120. So if your patient is in AFib rhythm and the heart rate increase more than this, so it can be one of the side effects of dobutamine. What do we do for AFib RVR? Metoprolol, what is it called? I suddenly blank out. But yeah, we give metoprolol and amiodarone. Yeah. So I think that is it. So before you guys go out, I have this very beautiful slide that I want to show you guys. This is one that I found from Max Call MD. This is called a pressure rainbow. You guys should take a screenshot of this because it's a great slide to study and reference and recall these vasopressors. So they have from phenylephrine, norepinephrine, epinephrine, dopamine, and also other drugs like mironone, vasopressin, dobutamine, isoproterenol. Okay, so with that being said, thank you so much for watching my video. I hope I made this as quick as possible, and please follow me on Instagram. Peace.